I've been in practice for many years, as Hitesh has mentioned, and there are definitely gaps in our care for diabetes. Diabetes is a problem that is worldwide, and of course, many people suffer from it. And with these times that we have, it is probably wise to know what we can do better about it to make it a better place for everyone. Um, as you know, diabetes and medical care has evolved over time. There always has been traditional medicine where people have gone and seen their primary doctors. And a lot of times the discussions are primarily on a hemoglobin A1C that was done or a blood sugar test that was done. And if they brought their meters in, then their glucometer would have been occasionally been downloaded and maybe discussed. But that's pretty much what happens in our offices without the help of the latest technology. And a lot of times it's something like what's mentioned on the screen, that I have your lab results and some of it is high and low and they don't balance out, but here you go. And this is pretty much what we can do. So medicine definitely has evolved over time. Uh, with the advent of diabetes being detected much earlier, now that we check A1Cs at the age of 35, and even earlier if you have a lot of other comorbidities such as high blood pressure, high cholesterol, heart disease, and so forth, or if you have what we call gestational diabetes, if you have diabetes in pregnancy, again, it's checked at that time. Glucose levels have been detected at much earlier, lower levels than they used to be. When I started fellowship, the detection was at 140. Now it's at a fasting of 126. And we even talk about sugars more than 100 to be in what we call impaired fasting glucose, and A1Cs as low as 5.7, which we consider as pre-diabetes. The actual definition of diabetes would be an A1C of 6.5. So with all this advent, it's hard to practice just traditional medicine in order to achieve where we want to be. And as you know, people can be stuck in their ways. And I have practiced endocrinology throughout the entire spectrum. So I did my training at LA County, USC, which is a very typical county facility, very sick patients. After that was at Cedars-Sinai, which is in Beverly Hills, which had a very different affluent population. And then moved on to UCLA and was on faculty there, which is another affluent, semi-affluent area. And then came to the Bay Area and now have two practices. One is in Los Gatos, which is affluent, and one is at Regional Medical Center, which is not affluent. And you see a whole spectrum of how diabetes is managed and how the people in Los Gatos, some of them come with every possible machine that they know of or they want to be on, and their insurances pay for it. And whereas if you go to the other side, then they look exactly like this man here with the large phone and the large, clunky stuff that he brings in, and he doesn't want to change. We have a fair number of patients who don't want to change, who don't have iPhones, who don't necessarily want to get a new iPhone. They want nothing to do with technology at all. And so you're dealing with two varying types of populations, also from a different socioeconomic background, from a different cultural as well as education background, that don't necessarily understand why they would need to have these kinds of devices or apps or any kind of structure to help them with their sugars. They resort to using very, very old meters that can be downloaded and so forth. So we definitely have a very different kind of clientele all over, and we have to have different approaches to treat diabetes in those kind of clienteles. As you have noticed that some of these patients that I'm talking about in the poorer areas do not have a ride to offices. And that has always been a challenge. They always cancel their last minute visits. They usually don't bring their meter. They forget. Translation is usually a big problem because they speak either, Vietnamese, Chinese, either Spanish, whatever it may be. It gets hard to communicate across and tell them exactly what you're trying to achieve and the importance of it. a lot of them don't realize that unless these sugars come down, you're not going to have a good outcome and you would have a lot of complications. So telemedicine, which I think has been around for a long, long time, only COVID made it actually more possible, where the insurance companies also realized that probably the entire health system will crumble if we don't start having telemedicine. And so a lot of our offices started doing telemedicine, either by talking on the phone or even through some kind of a platform such as Zoom or whatever the hospital or Kaiser or Stanford or whatever might offer, for patients to be taught about diabetes through the computer. And so the convenience factor became very high, and you could reach out to people who were in the boonies, people who lived in places where there was no endocrinologist or no doctor for miles together. I have patients who are sitting happily in a mountain home somewhere and can be seen for their diabetes. And then of course there are some who live very, very far away and they could still be seen for diabetes. There was somebody who lost their home in the fire a year ago and could still be treated for diabetes from wherever they were. So the convenience factor has been a huge, huge bonus. And it has sort of transformed the way we look at medicine and its care. And of course, doctors are paid nowadays for this telemedicine, which never happened before. But telemedicine sometimes can be good and sometimes can be bad. Now you can see that this person is a dentist trying to tell this guy how to use a drill into his teeth through the computer. Now, I couldn't find something that was alluded to diabetes, but I think in diabetes, most of diabetes is a relationship of trust that has to be developed with your patient. And to develop a trust with a screen in the middle is kind of very, very difficult. How many of you would like to buy your car through a screen without even seeing it? Or how many of you would like to buy a fancy television that costs $5,000 just looking on a screen? You would like to go to the store and check it out. It's the same way, it's with patients. They feel that when you're being started on insulin or you're being told to do something new, that you want to develop trust with this person in order to feel comfortable that they are actually giving you the right advice, and you don't get those vibes when you're talking through a screen. It has definitely helped us to talk about nutrition aspects or to explain to them just diabetes in general. You could see how their house looks like. You could see what their surroundings are like. Of course, there's a convenience factor, as we mentioned, but what we don't get across is the trust, the hand-holding, the emotional component that doesn't exist with it. And I think that is something which is very hard to achieve through telemedicine, and it will always remain that way. So it definitely cannot solve all problems. And then I saw this slide and I thought it was kind of scary that the surgeon thinks that they can do surgery via Skype, and so that people should just go home and lie down in front of their computer. I recently actually had shoulder surgery at Stanford only a week ago, and I don't see my physician for the next 6 weeks. A lot of my visits are in between are on the computer. But I think me as a physician, I don't really mind that because I don't want to really go all the way to Stanford either. But as a layperson, I think it might be quite frightful to have stitches in your arm and nobody really seeing you. I'm not quite sure. So we have to realize how much telemedicine, how much we want to use it and how much we don't. So medicine has always been evolving. And right now, as far as the care of diabetes, we monitor it. We have there's so much of artificial intelligence. You could predict how blood sugars are going to rise with all the new sensors that we've been using. They actually can detect how the blood sugar will be rising over the next few hours, whether it's going to fall, whether you're going to have a low at night. So there are lots of things that it can tell you. So just a little bit of history about blood sugars and their sensors. The first time the sensor came about was, I think, around 2006. And it came with the help of insulin pumps. So insulin pumps are devices that give insulin to a person, primarily with type 1, but we use it with type 2 as well, through a tubing, and it gives you around the clock insulin delivery. And so one would naturally want to know what one's sugars are. And so the first Medtronic had the first insulin sensor, this first sensor device, but it was never a closed loop system, which means that the sensor never really talked to the pump and so forth. So it was like two separate entities. But that came out in 2006, and we would use them in our office, and we had to put it in a big black box, and so that it didn't have any kind of problems with connectivity and so forth. And it was kind of very, like, it was like magic in those days, but it was around. And then slowly over the years, we've had different sensors come about from Dexcom and from Abbott, and they've become more and more easy to use. So we have 70% of our practices are now with these sensors. So patients just wear them for 2 weeks at a time, and then they can be downloaded in the office. And we kind of can know how they're doing at their sugars, make our changes. A lot of the times they can be transmitted across through us, through some codes and stuff like that. And we can actually do it through telemedicine as well, which has been really nice, especially in COVID. So I'm not really going to go through all these different things. You can read it for yourself, but a lot of it goes through what we call the electronic medical records, whereby a lot of these things are tracked, prescriptions and medication refills can be sent, appointments and telehealth and patient portals are available. And then of course, there's always the people in the picture, where you would have diabetes forums, social groups, but again, they can all meet on an app or on a portal someplace. So everything is evolving. And there's a smart everything available. So except, I don't know, we need to still find the smart doctor and the smart patient, but it seems like we have smart for everything else. We just talked about the continuous glucose monitors. We talked about there's a smart watch, there's blood pressure monitors, we have smart EKGs, you can do them in your house. There are smart drugs, which this is the gastroenterologists use them. You can see them as cameras as they go down your intestines, and all kinds of things. Smart everything, as I call it. But at the end of the day, physicians are designed to be, they were taught when it all evolved, they were taught to always take history taking and do a physical exam. And I think at the end of everything, I think that would be your mainstay. However much technology comes in your picture, technology is always secondary to what is being told by the patient. They say that 90% of the diagnosis lies in the history of what the patient is telling you. So if you just sit and listen to them, you will get your diagnosis. There are several companies, as Hitesh mentioned, who have come out with several technologies that help with downloading and sensors and detecting data and helping patients bring things down. But I just thought that I would give you the reality of how it is in the real world, seeing patients, a lot of diabetes patients every day. So I thank you for listening to me.